Dr. Eduardo Simoes. He got his medical degree from the University of Pernambuco in Brazil, which is also, it's a 6-year medical school. We were talking earlier. That degree is given in conjunction with Oxford. They would trade years with students from Oxford coming to Brazil and students from Brazil returning to Oxford, and kind of a cross-cultural arrangement. He was a assistant professor and adjunct professor in St. Louis University in the School of Public Health. At the same time, he held an adjunct professorship at the University of Missouri. That was in '95 and '96. And while he was also a professor at both institutions, simultaneously he was the director of Prevention Research Centers for the CDC. So he has held multiple simultaneous positions in public health and epidemiology. Currently, he's a consultant to the World Health Organization, CDC, and many other institutions. He's published more than 80 peer-reviewed publications, 4 book chapters, and more than 30 official reports in public health and medicine. He's made over 100 presentations in health-related conferences and is a reviewer for 12 peer-reviewed journals, basically dealing with public health issues, and is the associate editor of International Scholarly Research Network, which publishes peer-reviewed journals covering a wide range of academic disciplines. And he's currently the chair of the MU Department of Health Management and Informatics. Dr. Simoes, thank you for speaking.
Thank you, Steve. Let me put myself on this. Can you all hear me on the back? Good morning, everybody. Good morning. I think it's about time to do the exercise so people don't sleep. You already had 3 presentations. I'm very honored to be here. Thankful to this school to accept me as one of them. Especially thankful to Dr. Churchill for his vision, his tenacity in pursuing quality and excellence, and for pushing us to the right direction, I believe, in delivering the best medical training and research we can give to Missourians and to people from all over. The topic of my presentation is actually part of my experience. Let me put in a context. While I was at CDC for many years, I had the opportunity to participate in many committees. And one of the most important committees of my short professional life of 30 years was the planning committee for the Clinical Translation Research Science grant that many universities have applied over the past 6 years, and successfully so others did. I think we did apply twice, right, Dr. Churchill? And we're going to apply again. So part of this presentation is actually a presentation I made 4 years ago that I refurbished and produced a presentation about a year ago at Washington University. And this is meant for a big picture. It's supposed to be a little bit longer presentation than the 30 minutes I have, and I'll try to cut and go straight to the chase. Cut the chase and go straight to the topic. The main purpose of this presentation is to generate some kind of awareness about policies around research in medical and health practice, so that we move forward in terms of what we need to do for a modern healthcare system that the American people need. So that's the context I'm giving to you, and we're going to start the presentation. We're going to give a very short overview of the health needs and high cost of care, and we explain why. Steps to close the research gap, changing research paradigm. That's the main focus of my discussion. And that was a recommendation for the feds, and some of them have been followed and pursued, but many of you may be involved in committees in policy and high-level decision-making. That might be helpful for you to help us to get where we need to go. Suffice to say that we have one of the most expensive healthcare systems in the world, and the reason why we have one of the most expensive healthcare systems in the world is because we do not have a healthcare system. First. Second, we don't know if we need one, and I think the jury is out, and the American people is actually going back and forth about these ideas. I'm not going to discuss them. I'm just going to say that at the rate we're going, and even today with all the effort by the feds trying to control cost, it looks like they're increasing cost. We're going to be around 17% if we're unlucky, and about 12% of GDP. It's unheard in the modern world that we go so much, and is still ranked about 87th to 95th percentile of the worst quality of care in the world. by the World Bank, World Health Organization, many other organizations. I don't know if these comparisons are fair, but that's our reality. And part of it is because of this type of expenditure patterns. As you can see here, we have locations in the US with a per capita expenditure of about $5,000, where in other locations we have per capita expenditure of over probably $8,000 to $9,000. So this enormous variation per capita, this is all fully adjusted to age, sex, race distribution, and comorbidity. It's the main reason that the federal government is so worried and putting so much effort in research and monies for applied research that we need. And that's why we all got involved in public health and delivering that research. Remember, the feds are the biggest health payer. They're just a payer like any other. And they're just concerned. Another way to look at that problem, it's variation and utilization. These are per capita adjusted, normalized ratios of the hospital systems procedures. Specifically here, we're talking about how many orthopeds we have here in the crowd today. Hip fracture, knee replacement, hip replacement, back surgery. But I could have picked any group of condition in the same group of areas. So you can see here that compared to the US, that's the normalized US is one. Should be here in this slide. You have variation like that. In this place, these health systems here are doing something close to 2.5 to 3 times more procedures per capita adjusted for sex, race, income, and comorbidity. So there's no real reason why a group of health providers and health system could be so high compared to this. Between this and this, there is a tenfold separation. So is that possible? That's the reason why we're in the business of healthcare research. Is it all because of poor research? Not exactly. But poor healthcare research is part of the problem. So, and that's what I'm going to try to address here. I'll give an example to you. A Canadian Cancer Society request for application was I think it's 20-some years old. Some people came together and said, well, let's do a study, see if they reach what we are supposed to be the outcome of this type of RFP. The question on the RFP is, are group counseling program for smoke cessation effective? If so, what's the optimal content of the sessions? What is the optimal number and frequency of sessions? What are the characteristics of the most effective facilitators? Remember, this research was done in 2004. These questions were asked with an RFP 25 years earlier. So these researchers in 2004 reviewed the literature based on this RFP, and every researcher came out of it. And they learned this. After comprehensive review, including unpublished studies, there were deficiencies in purpose, design, and reporting for most studies. There's not a single one that could be considered like a perfect study or closer to. Researchers could only answer the first question after 40 years of research. Are group counseling program for smoke cessation effective? Yes. But nobody knew what's the optimal content session, what's the optimal number and frequency of session, what are the characteristics of the most effective facilitators and sessions, and so on and so forth. Therefore, you know you have a problem, you know you need to act, but 25 years later, after millions of dollars, you don't know how to actually implement this. This is an example I'm bringing to you. I reviewed the literature. There are like tons of things like that in medicine and prevention, but also in curative care, palliative care. We know what the problem is. We don't know how to implement, how to replicate, because the right research is not done. So, insufficient translation of scientific knowledge into patient care and disease prevention clearly is a problem. Insufficient diffusion of the evidence-based treatment and prevention practice, it is a problem. But a missing component of the evidence-based practice is this outcome and system-based research, and that was my call to them back 4 or 5 years ago. There's not enough experiment or much of the wrong experiments. And that's what I'd like to discuss with you. I'm going to give you a background besides that on what the feds have done over the past 6 years. Also, there's this separation between treatment of individual and disease prevention population, which is unique to the United States of America. And we all have to understand this. If you travel anywhere outside US, to the south or to the north, Canada or Mexico, or to Europe, or to Japan, or to China, or to any African country, or Latin America, any Asian country, public health in medicine are one. Here we have a separation starting in 1917. It could be a whole lecture. I'm not going to get there. But that creates a lot of problems for understanding, for the mindset needed to do the right thing. So some of the steps to close the gap: practitioners to implement the lessons of research by translating them into practice, recognize the research and practice as separate disciplines. We need to produce scientific knowledge that inform health policy and practice, not just inform general ideas. Oh, this is a problem. We have a hypothesis test. We have a p-value, and this is science. No, we need to say, how do I tell a policy measure? How do I tell a practitioner what to do? That's what we need, the kind of research we need. So steps to close the gap that I advance, one of them is non-traditional view of research evidence. I'm going to go over that with you all today. That's one of the main reasons of the presentation. Patient and population, what I call community-centric health systems, view as opposed to individualized little system, or one disease at a time, one practice at a time, or one patient at a time. System-based modeling and research, critical. Bridging the gap between medicine and public health. It's a political statement, my philosophical statement. I have a paper that tells a little bit about that. If you're curious, you can read that in Journal of Primary Preventive Medicine. So what the feds have done, they've done a good job here, and I highlight a few articles that address some of those issues. Fontana-Nosa on Basic Science and Translation Research in JAMA was one of the first articles to kind of provide the feds with a view where they needed to go. So we're talking about bench to bedside, production of new treatment that can be used clinical, brought to commercial markets, closer to that vision I mentioned early on that we need to go in terms of science. And this is a little bit of overkill on the Westphal model, which is basically a little bit of an advancing the original idea of translation research, and that's why the name of the presentation, Beyond T3. So we have T3 here, dissemination research, implementation research. That T3 here assumes that we have the right research by calling practice-based research. My criticism is that after 5-6 years of translation research science, after many years of comparative effectiveness, which is the right direction, at least in term, we still have a very traditional view of science, and that is affecting our ability to actually deliver the right healthcare models that we need in practice. So this is the last 2013, you go there to the NIH website, and you can find this beautifully put together model. And a lot of those things are better than we were 10 years ago, absolutely. But still, at fundamental level, we still have a problem understanding research. So you have now at least the idea that we need to go from basic science to clinical, from clinical research to patient, from practice-based outcome to practice, and from practice-based systems, research to system. People can say that in different ways. At least they're advancing that. And here what we're talking about is a system that may allow an animal studies to move on quicker in this lines year than they were before. Instead of the 25 years lag between the basic science research to this, we will create a system by which an idea can move faster and get to the clinical and the bedside, absolutely. So at least they have that concept. Duke has a very good model on that. We could talk about just that model and highlight this even better. Funny is, Duke University was not refunded. They apply again, and they got kicked out of the list of funding for this activity. Now, the feds at Alpha put a lot of effort in comparative effectiveness. That's another way. Back when I did this presentation, they didn't have that. So it was one of my recommendations, comparative effectiveness, with many others, not just me. We need that. And we all know that. Now we are in this environment for nearly 10 years, so I don't need to take much time spent on this issue. But it's basically, you need to have at least 2 or more effective treatment being compared for their what? For their cost effectiveness and for their applicability, for their, are they viable solutions for the practice? That's what comparative effectiveness should be doing, and it's doing. And I'll leave the presentation to any of you can follow. There's a model here that is very interesting from Tufts CTSI that address not only the translational, but gets a little bit of the issue of comparative effectiveness. Another movement that the feds have supported and have gone in the direction that we are recommending back in the times is the patient-centered movement, and many of you are aware. Instead of creating health systems, the research, just look into the health system as was, which is basically a health system made for us, physicians, or for the health system itself, but not thinking about the patient, we have to move the system to address the patient needs in such a way that the patient is the focal area of your interest. Yesterday, we had a conversation with a Howard Epstein. Anybody knows him from Minnesota? They're a consultant. They have a consulting firm, work with many hospital systems in Minnesota, in the Twin Cities. And he was telling me what he's doing. And I said, well, that's funny. 27 years ago, I was working in a rural health system for northeast of Brazil. And one of the aims of that system, and the little evaluation we've done, is to make sure that when a patient comes to a clinic at that point in time, everything was ready for that patient. So that patient would not have to go back 30, 40 miles by bus that they don't have the money to pay for, to buy a medication he couldn't afford to, and to go to a specialist he needed to come in another day he couldn't afford to. So it's one shop, and you have it all done at that point in time. That was 27 years ago. Many countries have done that for their poor population because it was a need. There was no other option. But here we're thinking, 27 years later in American people are, oh, in Minnesota, we don't know how to do that. Mayo Clinic is doing that very well. You go there, they are renowned as the diagnostician, and once you go there, they take care of you. You go to the hotel, they have almost like a concierge. You don't need to be rich. You just need to be able to afford that care, and if you need to go to a specialist, to a physical, they do everything while you're there for 5, 6 days, and you go home. Well, why we need to go to Mayo to do that? Every clinic system should be able to do that. That was my point. Well, research to allow us to make this thing cost effective is not done enough. And that's why a patient-centered movement on research would help us to get there. So the feds have done the translation research, but I still ask the question, there's a lot of discovery. What discovers, what research, what practices we're talking about? So I have a general recommendation. We're going to try to take another 10 minutes on that, or maybe 15. Expanding the research model, but still traditional, forward-looking, and traditional designs. What I'm meant to say by that is that even the existing research at that point in time, is still today, doesn't do this in the right way. You're trying to move into research by the RFPs without having the benefit of piloting real-life experiments. So I give this as a cookbook on how to go about it. We tested that for 9 years at the Prevention Research Center at CDC, albeit more focused on prevention and health promotion than curative or palliative care, but it worked. And I'm not going to go and take too much of time on this because I want to go to more controversial issues. But there's a cookbook, stepwise way of going about this type of research that expands the traditional looking, but still using traditional forward methods and design. So there's a whole part of the lectures about the criticism of the traditional view in medical epidemiology. I'm a trained medical epidemiologist. I've done a bunch of designs and studies. And I accept some of the criticism with a grain of salt. But I just wanted to highlight that it's awfully inadequate. Many times in my short experience in trying to understand complex systems, what we have today in practice, complex medical system, trying to understand that with a very, very structured research design meant for something completely different. RCTs, even some of the traditional observational research designs in epidemiology, they are not meant to address complex health systems. And I have not only theoretical but hands-on experience in complex health systems, mostly, unfortunately, outside the US. But we learned a great deal about quasi-evaluations and experiments, and that's what did it for us. Some of the criticism I'm going to highlight with an example here, and it's published by these folks here. The Acts of Clinical Research in the Third World, an Ethical Trial of Intervention to Reduce Perinatal Transmission. And that was a big study done by the Centers for Disease Control, my colleagues. I'm not going to mention names. And they didn't have any bad intention in their bone, guarantee you that. But they've done something extremely unethical because of their mindset, their training about research design, the classic research design. So in their view, they're doing the right thing. Making a long story short, and I'll leave this presentation to you because I didn't realize you had a 30-minute presentation. I thought it was 1 hour, so I'm going to move quickly. But they basically created a design in which they had this type of design. For those who are not familiar, I'm going to basically say this is the classic experiment design. You have one group, you have the intervention, the other group receive placebo. This is the first measurement, second, before, and then third and fourth measurements after. And you have outcomes, you have endpoints. I'm simplifying a lot of stuff here. So the participants are HIV positive and pregnant women. And this research was almost the reason why they closed down CDC because of that. And for 7 years, 6 years, I think, we had to ask NIH permission to do research after that. Okay? When they could have done a design like that, I'm not going to get into that. You can read the papers and understand about AZT protocol. Bottom line is, because their view of science, when they deal with complex systems, complex situations, they forgot how to be ethical. This is just one of the criticisms. There are many others. Most criticism I have about randomized clinical trial is that it doesn't work for complex systems, where they have way too many parameters. Let's think about other models. Change the traditional research paradigm. I'm going to give a few. From experimental to observational trials. What about, instead of the RCTs being the golden standard, the ultimate goal of the research, you start with something simple, observational design, get some smoke that looks for fire. Let's test if there's fire with the RCT. That's a traditional view. We increasingly go from a lower level of internal validity to a higher level of internal validity. So we know that the causal relationship is stronger. And I truly believe in that. I'm not saying I don't believe in that. Just in a complex system, that linear model doesn't work. And I'm going to, hopefully I'll have an opportunity for some of you to be interested. We can talk about it. We can create a lecture about that. So effectiveness. RCT still hypothesis generated by closed confirmatory. Now, under this new vision, there's a guy who wrote a very good article on that. There are many, but this one is one of the best. I want you to read it. Under hypothetical deductive logic, RCTs are considered exploratory and observational confirmatory. It's the way around. Instead of using the observational design, a cross-sectional study, a case control study, quasi-experiment, an evaluation, to say, well, there's something there. Let's test this model with an RCT. Being the RCT being the final word, the RCT is actually the beginning. It's just raising the possibility that that thing is actually viable. Some things they are very okay in a linear model that works okay. In real life, with all the complexity, it will never work. So it's better to have something less effective that's highly acceptable, highly implementable, highly disseminable, whatever the word for it, than something that's highly effective that nobody accepts, system will not adopt, and it will be impossible from a cost-effective political, social, and cultural norm perspective. And that's why we end up with the traditional view of science, with lots of great intervention that only work on paper, on labs, or mimics of labs of real life. So that's a different paradigm in going backwards into the validity. But also we can be even more specific from external to internally valid. And there's a good article on that by these folks, especially this guy, Dr. Victora. Dr. Victora is a friend of mine. We studied together at London School of Hygiene and Tropical Medicine back in 1986. And he was graduating and became a big star all over the world with reproductive health. He basically is the guy that single-handed proved that the main reason we had so many cesarean sections in Brazil because doctors were making a lot of money. I know people are not going to like that. He's a doc, and he's a good gynecologist obstetrician. But he did what we call real trials, not randomized trials. And he repeated over and over and came up with the right stuff. So I'm giving his article, you can read it. There's another view of it, non-linear, it's called bottom-up. You start with practice-based observational research and evaluation. What that means, we've been hearing that from NIH for quite some time, practice-based. So we start from the practice. What has already been adopted? For instance, before the first trial on cabbage was ever done, people were already doing cabbage, weren't they? For those who are way before, many of you were, way before me practicing medicine, how many years have we been using open heart surgery or anything like it, even before cabbage? For coronary bypass. Coronary bypass, how many years have we been doing coronary bypass? Does anybody remember? 60s. Early 60s, actually. Early 60s here in the US. Well, only 40 years later, we had the first trial. What that means, it proved the wrong? No. It means that if I had observed the practice done evaluation of that practice. I know it's widespread, wide accepted, and effective in its delivery. So I know it can be implementable. It's already implemented. That's just an example. And then I move forward in a little bit more organized study, let's say a quasi-experiment. And it's still working. It's still delivering the outcomes I want. I already know it externally valued, highly acceptable, highly viable to be implemented. And then I go and finish up with a randomized trial to tell exactly how much outcome per unit of intervention I have. And that's good for policy. That's good for science. But it's moving backwards in the paradigm of research. So that's what I was proposing NIH, and they are considering how I know they're considering. I'm going to skip that one. It's called plausibility research. And I also wanted to, before I finish, I wanted to highlight models like that. What is this model here? This is a translational framework for public health research. Well, when the Brits call public health research, they're calling medicine. That's their view of medicine. So everything is together, and their research enterprise does not separate the pieces, does not separate the complexity of the system, including communities, patient as part of the system, and more importantly, prevention and promotion all together in one piece through primary care. They have a strong primary care orientation. So a lot of that is being tried, is being talked about, but the research framework isn't there for us to move forward. So I give you that one. So what else you need? I'm just going to close with this one here. This is my personal fight. Improve health through education, research, and provision of evidence-based practice. That's a shared mission between medicine and public health. I'm going to go here. I'm going to give this report, Primary Care and Public Health Explore Integration to Improve Population Health. This is an IOM report that colleagues of mine from Duke and many other universities together with NIH put together. And I want you to pay attention, read this policy recommendation. There's an incredible opportunity to do research together between public health practice and medicine that's being missed. Primary care practice is the closest to public health practice you can get in medicine in America. And we missed the opportunity to help each other. Great research, great design, understanding the complexity of healthcare delivery for US. So this IOM report delivered that in a very elegant way. I'm going to just leave you with that. And my last word, it's on this. This is another of my contributions to the Prevention Research Centers program at CDC. You cannot have sustainable interventions either in primary care practice or even specialty if you do not have the community, the patients buy-in. So a participatory process and implementing large-scale policies or programs that requires total compliance from patients and communities needs to involve them. So we developed a research strategy called community-based participatory research that others have written about, Kellogg's Foundation, but we actually designed a practical way of implementing that. So I recommend you all, when you go out of here, take some of those 4 or 5 lessons out of 8 that I kind of forward to you, this new paradigm in research, the participatory process, a more integrated view of public health and medicine, and then the research paradigm, the research framework become more applicable to realities of the outcomes we want to change in health. And with that, I finish my lecture and I'll open to questions. Thank you.
Thank you, Dr. Simoes. If we have questions, if you would try to use the mic, I'll bring it around to you. Anybody has a question?
In any sort of clinic or practice or institutional setting, who have been successful and what tools have they used to encourage the bottom-up flow of ideas that will improve patient care?
Very few. And that's why we keep trumpeting, we keep bringing presentations like that. However, if the research money is there, there will be many. What happened is this. The funding streams for research by the feds are still very much verticalized, traditional, and oriented by research review panels in which the researchers only have experience with RCTs. So they never tried anything out. So even if you try, you won't be able to get it. Even if the language of the RFP is kind of a little bit open, allows you to submit that, you won't get funded.
Well, let me ask you this. Out there in the world, how many good ideas are there that are carried on at a pre-research level that we need to tap into?
lots of it. I'll give you New Zealand. There are about at least 5 or 6 papers on healthcare intervention, especially primary care for New Zealand, that have been implemented. They've done practice-based research and reoriented. I can give you my card and I'll send you the publication. You can read them. And actually be implemented by the New Zealand government. Australia, England. I helped to convene 2 panels in Canada because the Canadians were open to the discussion. I brought a few colleagues from NIH to this discussion. The Canadians have done great research on that, applied practice-based research, and then moving backwards and getting to the level of evidence we need so we can get more detail. So I have tons of examples for sure. Outside, not much in the US because the funding streams for research.
Will widespread adoption of electronic medical records alter achievements?
Did anybody hear that?
Electronic medical records, will that help us achieve this goal?
Okay, that's a better voice than mine. Mine is better. I don't think the electronic health record is the issue. It should not help or, I mean, I don't think it affects this issue we're talking about. I think electronic medical record in itself is very important because everybody already adopted. It's almost like saying you cannot live without it at this point. But I warn you, there's a good article, even though I'm the head of a department of health management and informatics, I should be able to sell health informatics. There's a recent review published in EMEA journal, JAMA, in, I think, February of 2012. In this article, they've done the most comprehensive systematic review of electronic health record, electronic medical records, and outcomes. And they found no evidence whatsoever that improved health or reduced cost. Doesn't mean it doesn't. You say they didn't find evidence.
But using the data that we get from the EMR, we'll be able to start, I think, asking or seeing more of this data, asking simple questions. So I'm thinking that it's an exciting opportunity to be able to ask a simple question, look at the data over a wide, that you've gleaned from a system of EMR, and then go back, like you said, with the observation.
Absolutely. I think maybe this is another way to answer your question. That way, I agree. The EMR offers incredible opportunity for within systems to do a research. Unfortunately, it's nothing to do with the technology. Policy and money dictates how these things exchange. So the HIE, Health Information Exchange, you never be implemented as we idealize, as the Fed think it will be. Because every health system have their stronghold in their market and they won't share. Tell Cerner to share with what's that, Sigma? Sigma, I forgot the name. There's no way. Within that system, they will keep their system in. But it allows us the opportunity to get to data we never thought before. But remember, garbage in, garbage out. So if you enter bad data, if we don't have systems of standardizing, normatizing what we're collecting, we're not going to get the data to do the systems approach. But it offers incredible opportunity for systems view, complex systems of delivery of care. They are acceptable, definitely. I think it will help. More questions? Dr. Churchill? No question?
Well, I mean, having a medical record and having data is not the same as having information that is translatable into, treatment or even studying populations. I think that's the challenge right now, isn't it? I mean, how do you really change this data into something that's more useful than just, doing these dumps to drag it out of the EMR? I mean, there's got to be something else.
Agreed. That's the main trouble with the technology right now. It's like how to make this information that goes into the electronic medical record into real information that not only can be used for practice but for research. The problem is you cannot have two masters and make it work. And our health system, any other health system, is a good example. Once you do better for clinical practice and delivery of healthcare, you create systems that are almost impossible to do research on. Okay? I could go on, and that's a whole different topic. You create honeycomb type of data systems and sets that nobody can analyze. It costs a fortune just to access that data. That creates another market of health information systems who prepare data for people to analyze. And it costs somewhere between $300,000, $500,000. Even here in the university, if I ask CERN, I need the data to do A, B, and C, they charge me $200,000. It's our own data. But that's the reality, because it costs time and money for them to prepare that data for research. But it's data that's good for clinical practice. So it's like we have the potential, but policy, regulation, market issues, more about profit and market issues, dictate how this data is actually being created today. So I have an enormous amount of data that's totally non-analyzable. More questions? Thank you so much.